While we give time then to the labs, we will start. We are going to start by presenting one of the pre-edited cases, and the idea is to promote discussion about the case of how to solve the case. This is a case of a patient. Well, first, my apologies. The slides are in English to make it easier to understand for the people who speak English, but I'm going to address you in Spanish, and those who speak Portuguese will be able to understand Spanish. But this is a case of a 59-year-old female patient who has had atrial flutter for 6 months, almost incessant, which was refractory to anti-arrhythmic management. In her background, a history of blood hypertension and obesity, and the patient had been taken to PVI 6 years before due to paroxysmal atrial fibrillation, and she had recurred in her atrial fibrillation for years after that procedure. Initially, these episodes were occasional and relatively not very symptomatic, and that is why metoprolol and digoxin had been started, but then they became more frequent until she developed a flutter, and that's when they initiated she initiated amiodarone, and she recurred, and she's referred back to our surface. The transesophageal echo of this patient showed an LVEF with mild dilatation of the left atrium with a preserved ejection fraction. This is the EKG of the arrhythmia, where you can observe that it is an atrial flutter with a ventricular response of 4 to 5 to 1, where there were no isoelectric intervals between the atrial activation waves, suggestive then of atrial flutter. I will not go into the details of the EKG analysis in order to promote the discussion that we'd like to have about the procedure. This is the map, but no, sorry, this is a prior ablation in this patient, the one that was done 6 years before, where you can see that it had been done, that what had been done was an isolation close to the ostium, almost an ostium independent of the 4 pulmonary veins, and also tricuspid isthmus ablation, also cavo-tricuspid isthmus. In the set of lesions, no summit line had been made, as you can see, and of course the posterior wall had not been affected more than necessary in order to perform the isolation somewhere outside the ostium, but this is not at the antral level as we do today. When the patient came to the lab for the atrial flutter ablation that I described 6 years later, this is the activation map of this patient in atrial flutter, and you can see that there is a great posterior scar, a large posterior scar, which had almost coalesced towards the summit with some preserved tissue here towards the lower portion of the posterior wall between the inferior aspect of the twin lower pulmonary veins. The upper left and right pulmonary veins were reconnected as was usual at the time when there was no availability of contact force catheters, and the reconnection gaps were also the usual ones. And the gap was anterior in the ridge that separates the left pulmonary vein from the atrial appendage, and the gap in the right upper pulmonary vein was also seen here in the posterior aspect. And the patient also had a scar, an anterior scar, as you can see here, which is usually seen in the patients with some type of heart disease that is causing some form of scarring in the left atrium. The initial approach during This case was to perform the isolation of the veins that required it and to complete the posterior wall isolation in order to avoid or prevent the patient from going into those gaps that you see in the posterior wall. At this point, Chief, I have just described that we performed the voltage map during the atrial flutter in the left atrium 6 years after an isolation. Chief, do you have any comment? Do you have any comment to make regarding the validity and the differences between doing a voltage map in sinus rhythm versus atrial flutter? What are the difference between the right and the left atria? Please. Muchas gracias por esa pregunta, Luis.
It's a so this is a yesterday when we were discussing this case, we wanted to bring this up to the team as a point for discussion. One of the big concerns in the field is, and this is an area where, in fact, I personally started off with the impression that sinus rhythm gives you the most reliable voltage maps. And that again comes from the bias of someone who does, we love VT. VT is our passion, but AFib is kind of important. And we use the same knowledge, just assuming sinus would be the correct way to look at voltage maps. And we actually did this study for right atrial flutters. And this was published by Bradfield, and this is a collaborative study that we did. And to our surprise, we found that the voltage map was completely different in flutter. And in fact, it even showed higher voltages compared to what we saw in sinus. So this actually tells you that there's a lot of cancellation of forces in sinus rhythm. And so some areas actually have lower signals and lower amplitude EGMs. And perhaps this is because of cancellation of wavefronts. So this is a point that you have to keep in mind, especially when you're looking at bipolar voltages. Now, we don't have standards for unipolar, and I believe you're going to be making some comments tomorrow also in your talk. So today, it'll be interesting to see, in one of the cases that they're going to be doing live, we are going in with an open mind. If the patient is in flutter, perhaps we should get the map in flutter, but still interpret the voltage map. And after you terminate the flutter, you can still get it in sinus and try to compare zones. But thank you for that. That's an important question, and many of you in your practice will be interested in knowing what you find, especially in left atrial flutters. And we're collecting data on congenital flutters, by the way, Louis. So hopefully in your future conference, you should definitely, being a congenital institution, you should present.
Gracias, Chief. Gracias, Chief. ¿Podrías explicar un poco más el concepto de
further the concept of cancellation of activation waves, front waves, and why does the voltage measurement impact in one rhythm versus the others? Sí, un poco más. Sí, es una pregunta excelente. Todo cuando decimos
using it in a very general sense. But if you think carefully about bipolar voltages, it is looking at the relative difference between two locations, and it's also heavily influenced by the wavefront of electrical propagation. So if two areas that are being measured actually have different wavefronts that come across that area, there are some areas where if a bipolar voltage, the way the electrodes sit, if the wavefront passes underneath that electrode, but it's in a completely different axis, it'll actually record a zero potential. So that's it's a recording artifact, if you will. So when we look at ECGs, we remember that all the time. If you see an isoelectric, say lead 2 in your surface ECG, you instantly know that L1 is going to be positive and L3 is going to be negative. We kind of know that. It's a similar kind of a concept of it's just measuring a difference between 2 points, and that's not the real voltage under that site.
Gracias. Es un concepto muy importante y que pasamos un poco de largo en los
laboratorios. In the labs, sometimes we miss. It's a concept brought from basic fundamental electrophysiology, and basically when we talk about wavefront cancellation in sinus rhythm versus atrial flutter, when we're doing voltage maps, we are affecting the bipolar voltage map because it is totally dependent on this phenomenon. What we don't know is how it impacts on the unipolar map, and that's what Dr. Kumar is telling us. It's a research field. and something will be produced in the future. It has some very important implications, of course, because we can do modulation of a scar when we don't understand the circuits, if they are changing constantly, and we cannot do activation maps. So we do scar modulation based on what we reconstruct in terms of voltage. And if we reconstruct a scar in sinus rhythm, which is different than in flutter, then it has key implications for the procedures. And for the time being, that's what it is. That's what we have. And it is a field that is waiting for additional research. So we will continue to move forward with the case. This is the atrial flutter. As you can see, the coronary sinus, which was from proximal to distal in the catheter, we see that the activation comes from distal to proximal, suggesting that probably the flutter activation is in the clockwise sense. The cycle of activation was 270 milliseconds, and this is the activation map in flutter of the left atrium. Of course, I put it on this fluoroscopy just with the purpose for you to understand the coronary sinus. It's not an integration method. This was done manually, this overlay, but it can explain very well the recording for the coronary sinus in this case, which is critical to understand the sense of the cycling of the flutter, which was clockwise around the mitral valve. Well, so what we did was, of course, to do entrainment. It was done from the anterior aspect of the valve, and you can see that we paced at 260 with the capture of the flutter, with an activation which was the same during capture versus flutter, and also with a post-pacing interval of 270, suggesting that this obviously was a I need help. Suggesting then that the entrainment was exact from the anterior aspect of the valve.
Y básicamente lo que hicimos fue de las...
The posterior aspect in the mitral valve, what we did was to do the same, basically, and the entrainment was exact, was accurate. You can see that the activation sequence is the same. The post-pacing interval is 290. This is captured in flutter. It means, and it suggests that that area of the atrium by the mitral valve is within the circuit. As you all know, when we have this type of flutter, if we do exact entrainment of two sites so opposite in the mitral valve, generally it is enough to consider that there is a macro re-entry around the mitral valve, which is the one that sustains the flutter. Well, if you please open your apps to do the voting exercise.
En la parte donde dice...
Where it says voting or vote, just choose the therapeutic option you will follow in this case. Obviously, if we are going to do ablation of flutter, we have to eventually choose between not doing anything, just cardioversion and identify triggers. But for this exercise, we just suggest three options, which are the standard options. These are an ablation line in the mitral isthmus connecting the posterior aspect of the mitral valve with the lower aspect of the left pulmonary vein, an anterior line trying to transect, and eventually it can go to the upper left pulmonary vein to an anteroseptal line in the anterior aspect of the mitral valve and the antrum of the right upper pulmonary vein. When you say anterior line, is it anterior to the appendage, to the mitral appendage? Yes, the anterior line, the standard anterior line that has been described is a line connecting the anterior aspect of the mitral valve, and it can be connected or anchored either to the antrum of the left upper pulmonary vein or a summit line. So that's why it's anterior. It's similar to what the surgeon tries to reproduce occasionally, and that's associated occasionally to infarction of the non-sinus artery when the anatomic variant comes from the circumflex. The anteroseptal line is a modification to the anterior line. The standard line is the anterior. The anteroseptal is a modification or the modified anterior that connects this aspect of the mitral valve with the antrum of the right upper pulmonary vein. Well, let's cast our votes. Who would vote for 1? Mitral isthmus, 27%. Is this in percentages or number of voters were? That's the majority in any case. And the rest is distributed between the anterior line and the anteroseptal line. Thank you very much. So what we did in this case specifically was to draw an anterior line. I remember then we were debating the difficulty of doing the posterior line or the mitral isthmus, and we decided to start doing anterior lines, which presumably, as was published then, despite they were longer, they were easier to do, it was easier to stabilize the catheter, etc. And we took advantage of a prior scar on that area. You could see the ECGs, which were low amplitude, so this scar is real. And we do a dual line, a double line, because with the first line we didn't achieve much, so we did a second line. This is contact technology. Each point was stabilized to do the ablation CT with enough contact vector, etc. And what we accomplished is this. The flutter changes from 270 milliseconds to 315 milliseconds, and the activation is very similar from distal to proximal in the coronary sinus. So let me just mention, and later we will dwell on this discussion of why we do less aggressive ablations of 20 to 30 watts for 15 seconds, 20 grams of force. And in the rest of the line, we are more aggressive and we apply 30 grams, 30 watts for 20 seconds on each application. Now, despite this double line we did and all the rest, this is what we accomplished, 315 milliseconds flutter. We did entrainment once again to see what happened because we had already done what we could, and we decided to do an activation map in order to understand how the flutter had been modified or whether it had changed to another chamber. This is the activation map for this arrhythmia. There is early activation, as you can see in this area, between the summit of the left upper pulmonary vein and the opening of the appendage. And it was still activating in this sense, although obviously the information we collected for activation was not complete. This flutter is 315 milliseconds, and we were able to record in the atrium was barely 180 milliseconds. So we do the entrainment, and entrainment showed that when we stimulated on the double ablation line, we didn't capture anything. In fact, this gray area is a scar. And we didn't want to edit the map any further, but I can assure you that all this area was unexcitable. When we stimulated below the ablation points, we didn't get any capture whatsoever. When we stimulated, when we paced immediately above the line we drew, but towards the mitral valve, we observed this post-pacing interval, which was 380 milliseconds, suggesting that eventually that area was outside the circuit. And when we paced close to the anthem of the right upper pulmonary vein, immediately above the ablation line, the post-pacing interval was still a bit long, but not as long as close to the mitral valve. So here we were closer probably to the circuit. When we paced from the left appendage, the interval was terribly long outside the circuit. So at this point, and once again we can vote, we had to decide at this point, and let me ask you, what would you do at this point with this information? Do we extend? That's an option. Do we extend the anteroseptal ablation up or down? This is what we usually do in these cases. I have seen cases where they simply extend up down to this area with a large ablation area. Very similar to the concept we use, for instance, to do the ablation of the corticospid isthmus. Another option was to perform a posterior mitral line. It is not rare to find patients that end up with an anterior and a posterior line, which has implications on pacing after the appendage because it's electrically isolated. Another option was more mapping, more entrainment, because it's unclear. And another option is simply to go to the earliest ablation zone and ablate the earliest spot. Which is your choice? If you have any questions, please don't hesitate to ask. I will be more than pleased to stop and try to answer your question. Can we see the vote? Can we see the vote, please? Well, here it is. Well, this is quite distributed. Most of you voted for the third option, more mapping and entrainment to better understand what's happening. Others voted in favor of number 1, to extend anteroseptal ablation, probably further down. And a few of you voted for 4 and 2. Ablate the earliest spot or perform posterior mitral ablation. Well, this is what we did, in fact. We did further mapping and further entrainment, and this is what we found. And it's quite interesting in this case. When we included in the map and we added the pacing of the right and left map, you can see that we accomplished a larger length of the cycle of arrhythmia. Let me go back here to go over some basic concepts. When we are mapping a macro reentry, which is this is a macro reentry, probably that should have been my first question. What's the mechanism? You could have reversed the flutter, although obviously the greatest probability is that eventually you change to another flutter or it's the same flutter with a slower gap. But the options are, well, remember that this area was non-paceable. We couldn't capture along the line point by point. So eventually to think about a gap in the endocardic line was more difficult. And the other reason was because the entrainments just next to the line were very poor, were outside the circuit. And that suggested that the area we ablated probably was no longer part of the prior circuit. Now, when we have a record of less than half of the pacing of the length of the cycle of the arrhythmia, if we think it's a macro reentry, there is one part we are missing. We have to look for it because probably it's in a different structure. And in fact, the mechanism suggested that there was a reentry because we were able to entrain. We were able to do entrainment, to do fusion, and we knew that it was entrainment. But in this particular case, to ablate, simply with this information is a mistake. It's a mistake because you are missing half of the circuit and you don't know where it is. Remember that at re-entry, the early zone is not giving you any information. In a flutter of the quadricuspid isthmus, the early zone or the early meets late area may happen at any place depending on your benchmark and your window. It could be in the lateral aspect of the mitral ring. So in a macro entry, in the early zone, you will move away from where you should be. What you have to identify is the critical circuit zone. In this case, if we had changed the window, the distribution of the window, probably the early zone would be somewhere else. So definitely going to the early zone doesn't seem to be appropriate in this case. The other options can be to extend the ablation zone. However, we shall check anatomically and see why that's not really appropriate. Go to the posterior mitral isthmus without having enough information of where the circuit is located. That shouldn't be our first step either, because apparently that was no longer a perimetral circuit because the zone was outside or beyond our scope due to entrainment. If we are going to do a posterior mitral line, we are thinking about ablating a perimetral flutter. But how to do that if this area is totally outside the circuit? You can no longer be pacing around the mitral valve. So in those cases, what we should do is to complete the activation, looking for other chambers, eventually the coronary sinus, the right atrium, of course. And if that's not the case, we can also go to the epicardium. But in this case, the easiest solution was to map the sinus and the right atrium. What we see when we add both activation maps is that we come closer to complete a very good percentage of the total cycle length. This is one of the keys when we are mapping atrial flutter, and you can see pacing with an early response in the upper segment of the interatrial septum close to the vena cava. And it suggests in this system that the activation was cycling in this sense. For some reason, look at the activation of the coronary sinus. It was distal to proximal. It was cycling in this sense, and the activation somehow went through the coronary sinus, activated the interatrial septum from the posterior approach, then came up, and there was like a bypass of the left ablation line, activating once again the anterolateral and lateral aspect of the mitral ring, and completing a loop, which suggested to be interatrial. So this has been published, and we have observed this in at least 4 or 5 more cases when we work with the anterior line. This is what usually happened. The line is not easy to perform. On the contrary, it's very difficult to achieve the bidirectional block, but we increase the cycle length. And when you do activation and entrainment tests, you realize that what you did was to enlarge the circuit involving the right atrium and a structure to do the bypass of the ablation line. What did we find with the entrainment? The junction between the upper vena cava and the septum, in front of this line, the entrainment was precise, as you can see here. The same post-pacing interval, almost the same cycle, and this suggests that it's part of the circuit. When we did entrainment from the distal aspect of the coronary sinus, the activation was exactly the same, the post-pacing interval of 20 milliseconds, suggesting it was within the circuit. And when we did entrainment over here, close to the ostium of the coronary sinus, we got the same result. This confirmed that definitely the circuit was interatrial. When we did entrainment from the lateral aspect of the right atrium, the post-pacing interval was quite long. That meant it was outside the circuit, and the same happened when we went to the posterior wall. Now, what is happening here? how, despite the fact that I ablated this region, there is a re-entry which involves both atria, although I have an unpaceable scar here. This is described in the literature. There have to be some interatrial connecting structures that are doing the bypass of the line we did originally and through the coronary sinus connecting and pacing back to the right atrium. Here you can see the line we drew starting from the lateral or septal aspect of the mitral valve, trying to connect to the right upper pulmonary vein, which is behind the vena cava. The dotted line shows the part behind the structure, which was part of the line, and the continuous line is closer to the mitral valve. So what's this structure? Well, of course, the structure we see here is a Bachmann's bundle. In theory, this is what should be doing the bypass of the endocardic line. As you can see, this is a very thick structure, epicardial mostly, and especially in patients with increased thickness of the atrial tissue with a very thick Bachmann bundle. So the anterior line probably in this case did not cause any transmural injury of the structure. And what we did was an endocardic but not transmural scar causing the bypass of the line. And there was also secondary pacing of the wave front of the anterolateral aspect. There were muscle connections of the coronary sinus with the right atrium, and it came back through the atrial septum, closing the loop or the circle. Yes, we have a question apparently. I'm sorry, there is no microphone. Yeah, anteroseptal. It's modified anterior. Now, anatomically, well, any line in the end is very difficult. When you do an anterior line, this is what you find. This is what you will have to transect, particularly in this type of cases where the Bachmann is so thick. So it's the modified or the anterior modified line for this type of patients. It will be very difficult to accomplish. Probably these cases where Bachmann's bundle is very thick, these are the cases that have been described in the literature to require epicardial approach to be able to have a transmural lesion. Probably this cannot be done with endo, and this has an impact upon antral ablation of the veins. If you do an extremely antral ablation of the right upper pulmonary vein, that means that your line is trying to transect Bachmann's bundle. This is one of the reasons why one of the most frequent sites of reconnection of the right upper pulmonary vein is in the superior aspect of the vein where the Bachmann is going through. And this is an area where we are very aggressive in the use of radiofrequency, more than in the rest of the areas, trying to avoid those relapses. Do you agree, Dr. Shiv Kumar? Very well. Let's cast a vote again. So we now understand the circuit based on activation, entrainment, pacing, and anatomy, of course. Now let's think about what should we do here. How can we do an ablation of this flutter? We can do once again do ablation of the mitral isthmus, including in this case coronary sinus ablation. We can do an anterior line to transect the backman if we said that the modified anterior was going to be useless. We could also potentially do ablation of the non-coronary cuspid, this, which is here, the posterior cuspid, as it is described in some anatomy text, just across the two atria. And a catheter in this place is very close to this part of the ablation. Another option is to ablate the Batman attachments or insertions. This has been published. Generally, there is a ablation of the insertion of the Bachman to the summit of the right atrium and the appendage. Which would be your choice in this case? Ready? Well, most of you chose the mitral isthmus to do ablation of the mitral isthmus and probably complete through the coronary sinus. And the rest of you are distributed among an anterior line from the anteroseptal to the anterior line, and also to ablate the Bachman close to the insertion with the pulmonary vein. And the activation was earlier during flutter in this case. This was a redder area. Very well. Let's review the anatomy to try to understand at least what we did and the therapeutic options that we discussed. Initially, this is a graphical representation. Dr. Shiv Kumar, I would like to thank, I forgot to do it at the beginning, I want to thank Dr. Shiv Kumar for the anatomy slides, which are spectacular, and he usually provides his slides to us for our presentations and the analysis of these cases at different meetings. So it's a big pleasure to have his cooperation, Dr. Shiv Kumar. This is extremely helpful to understand what we are doing. Very well. This slide by Dr. Shiv Kumar from the McAlpine collection is intended to show you what we did. We chose to go over the line from the right atrium, trying to accomplish transmurality. The endocardic line we did is this one. This is the mitral valve. This is the ablation line of antral isolation of the right upper pulmonary vein. This is the foraminovalle, which is close to the antrum in the techniques we do today of antral ablation. And the line connected the anterior aspect with this antrum. When we look at this section, this line over here, which is dotted, we approach it from the right atrium. And here we can see several structures. The non-coronary cuspid should be here, which I repeat is between the two atria. And it's close to the nearest segment of the line and closer to the mitral valve. That line goes above the foraminovalle and connects with the antrum of the upper pulmonary vein, the right upper pulmonary vein. In this specific case, what should we keep in mind? To explain the difficulties we face when working with this type of lines. Here you can see the muscle reinforcements of the bundles which are usually present in the left atrium. This is Bachman's bundle. And you can see that there is an area particularly close to the mitral valve, which is around this area, which is further away from Bachman's bundle. This is the area where the anterior wall is closer to the summit of the right atrium. This is the non-protected area of the anterior wall of the left atrium. And it's very important to keep it in mind. Here you can see the translucency. This asterisk is the non-protected area that you see on the chart. If you understand the anatomy, you can visualize that probably when you do anterior lines, you have less problems in this area because it's the unprotected area. There are no thick bundles preventing transmurality during the lesions. However, there are some cases described in the literature of interatrial flutter that were ablated from the non-coronary cusp, and this would be this area trying to complete this segment of the line. Personally, the interatrial flutters we saw, the 4 or 5 we have done, never the lack of transmurality was in this area. It was always closer to the anthem of the right upper pulmonary vein. And it is very important to understand this concept. When we draw the ablation line close to the mitral valve, we were less aggressive, precisely because that's the unprotected area of the anterior wall of the right atrium. If you have a stem pop over here in this area, it will be very difficult to correct, even in surgery. Dr. Chief Kumar told us about a case in which there was a complication in this area, and even the suture for the surgeon was very difficult to do and to control the accident. That's why close to the mitral valve, we are less aggressive when we imagine that we are going beyond this area. We can also see the echo to see how thick is the interatrial septum. So definitely we are more aggressive here until we connect to the antrum. And this is what you see in this translucent image. This is the non-protected area. So to apply it from the non-coronary cuspid, in this particular case, we didn't think it was appropriate because remember that the entrainment above the line next to the mitral valve was worse than the entrainment close to or above the ablation line close to the right upper pulmonary vein, suggesting that the ablation was passing closer to this area. So we decided to focus on this area. This is another image to explain why you can get some help with anteroseptal lines from the non-coronary cusp. This is the non-coronary cusp, which is opposed to the two aspects of the left and right atria. And this is another view of what I am trying to explain. The non-coronary cusp and the line crosses the Bachman, which is the structure that was bypassing the line. This is what we did. Simply, in this specific case, we didn't want to go to the mitral isthmus because of one reason. Because potentially the conduction was going to be delayed in this area, and also because of the mitral isthmus, and eventually the appendage would be isolated. This is the problem when you work with two lines. You want to work with one line only and to leave this area potentially with no pacing, increasing the risk of cardioembolism because of electrical isolation. So understanding the anatomy and looking at the echo of this patient, the ultrasound, this area was very thick. So we placed the catheter on this side. We went from the opposite side using intracardiac echography and 3D mapping, trying to imagine that somehow we were able to accomplish transmurality from the opposite side of the line, from the right side, and affect the Bachman. And this is what we tried to do here. You can see how we did opposing lesions in this aspect close to the antrum of the right upper pulmonary vein. And finally, we were able to revert the flutter. The tests showed bidirectional block through this anteroseptal line. The block tests, I am not showing them here, but they are very simple. You leave the coronary sinus catheter, we pace above and below the line, and we try to see the activation or the pacing. If we are stimulating or pacing above, the activation should be distal proximal. When it's below the line, the activation should be proximal distal. This is the way we can prove the pacing. Very well.
That is the cases that I wanted to present, Chief.
Do you want to give some comments about it?
Bueno, ¿alguna pregunta final acerca del caso?
Any final questions about the case or any comments?
Sí. El flutter era un flutter atípico,
Flutter is an atypical flutter.
¿no es cierto? Este es el
This is the clinical recording of the flutter. This was, it's not in the lab. It was the ambulatory recording, and you can see the isoelectric intervals between the flutter waves in all the leads. And we can see that it is simply an atypical flutter,
sugiriendo
suggesting
que la onda
that the wave might be positive in leads, in the lower leads. Usually when there are extraperitral flutters and the wave is positive and the lower the flutter is and it's counterclockwise, and therefore that flutter may have cycled in both directions. Now what we saw in the lab is the activation that I showed that came from distal to proximal in the coronary sinus.
bueno.
Well then,
ah, sí. No la recuerdo muy bien.
I don't remember very well,
Sí,
but
ese slide no lo incluí en la
I didn't include that slide in the presentation, but I remember that there was a change in the P wave. In fact, it is one of the success factors that exist when you do Bachmann transection. Far as I remember, the wave was more bifid because of the delay, but I cannot give you the details. I can show you later on the EKG.
Sí. Mira, yo sí, pero yo te digo que honestamente
Honestly,
terminamos moviéndonos de la
we
posterior.
end moving away from the anterior line because contrary to what it was thought that it was an easy line to do, it was very difficult to achieve a directional blockade, and that is not my experience only, that of Fermin as well. We did several cases here. We ended up extending the entire ablation in the septum, and this increases the risks for the aorta. When you do gadolinium MRIs, you can see enhancement, and you can see deposits also, according to what Chief told me, in the aorta because it is behind. And basically, we went back to the posterior line. Yes, that's what we're basically doing in our experience today, as we're doing the posterior line today, and we will be discussing it during the case. It ended up easier than the anterior line. The anterior line is longer. You may have a little bit more control over the catheter, but the problem is that at the end you will transect the Bachmann, and this is not as easy. And in fact, when in those 4 or 5 cases where we did ablation from the right atrium opposite to the proximal aspect, to the aspect close to the upper right pulmonary, but from the right atrium, it is not easy. It's very difficult to stabilize the catheter. You're coming down from the cava through to the septum, and it is not as easy. And for that reason, the first approach that we take is posterior line, which, and we will discuss this later, also has its pros and cons. Both the anterior and the posterior line, their possibility of success depends on the anatomy. If the isthmus is very thick and the circumflex between the cava and the endocardium of that line, you're going to run into a lot of trouble. So today we observe, we try to see on ultrasound, in echography, what it looks like, the posterior isthmus, the aspect of the septum close to the foramen ovale against the upper vein, and we usually start in the posterior line.